In Langerhans cell histiocytosis, you can have single lesion or multiple lesions. Here is an example of a single lesion, which is destroying the alveolar bone process in the crestal bone area between the mandibular premolars, forming a radiolucent lesion. While in this example, we have multiple radiolucent areas within the mandible, and in this case, it is more aggressive. Look at the mandibular central incisors and the bone loss surrounding them. For Langerhans cell histiocytosis, radiographically, we usually use floating in air teeth to describe the teeth surrounded by this radiolucent area caused by the destruction, and this is commonly seen in Langerhans cell histiocytosis or LCH. Langerhans cell histiocytosis occur more in children, more commonly in the females, more in the mandible. Microscopically, we see histiocyte-like cells, meaning that they have a large nucleus. This nucleus is pale and vesicular, like if it is having multiple vesicles inside the nucleus. This nucleus is having an indentation in the nucleus itself. It looks like kidney-shaped or coffee bean-shaped. Okay, if you look at most of the cells, you will see this indentation. And this cell is also having plenty of cytoplasm. If you remember the macrophages and the histiocytes when I used to describe them to you, they look similar to that. Mixed with these cells, you will find these eosinophils. That's why this tumor or this lesion is also called eosinophilic granuloma, because it has plenty of eosinophils mixed with these Langerhans cells. Langerhans cells, in this lesion, they resemble their normal counterparts, but they produce a lot of CDA, which is the surface protein present on these cells. You can request immunohistochemistry or immunostain to detect the CD1A and then to confirm your diagnosis. If you think that this lesion is reactive and it is part of TUGZ, then it will be CD1A negative. If this lesion or this biopsy is part of or is representing Langerhans cell histiocytosis, then it will be CD1A positive. So I use CD1A in the lab to differentiate or to make sure that I am looking at a reactive lesion if the result of CD1A is negative. Using electron microscope, these cells will show something called Berbick granules. They are found in the normal Langerhans cell. Okay, now we will talk about hemangioma of bone. Hemangioma of bone is like its counterpart in the soft tissue. It can be composed of capillary or cavernous sizes, but it is most commonly of the cavernous type, meaning large dilated blood vessels. And it can be like a small lesion, small radiolucent lesion, and the radiologist can tell from the trabeculation within this lesion. They have their own way in saying that this is most likely hemangioma. Okay, it can be a small lesion, it can be a more extensive lesion, it can show the honeycomb appearance, the multilocular radiolucency showing the honeycomb appearance. If you aspirated this lesion, blood will come out. And microscopically, it is most likely to be the cavernous type. Whenever we see a radiolucent lesion in the bone, the surgeons usually perform or do the aspiration to see the color of the fluid coming out, because it is not easy to open for a biopsy and then fresh blood will keep extensively bleeding if the tumor or if the lesion was hemangioma or blood vessel related tumor. For the metastatic tumors, Metastatic tumors can be like bone forming or radiolucent or bone lytic lesions. They can go to the mandible and maxilla, but more in the mandible. They can go to the soft tissues and the bone in the oral cavity. They can go to both bone and soft tissue, but they can go to the bone much more likely than metastasizing to the soft tissues. And if they will go to the bone, it is more likely to go to the mandible more than the maxilla, and in the soft tissues, more commonly going to the gingiva and the tongue. And I have seen a case of metastasis to the gingiva and another case in the tongue, and both were from renal origin or renal cell adenocarcinoma, metastasizing to the oral soft tissues. In the bone, the tumors most commonly metastasizing to the jaws are of carcinoma origin. They are not sarcoma, they are carcinoma, and they are of the BPB origin, breast, prostate, bronchus, in addition to the kidney, lung, bowel. These are the 6 tumors of origin that you should memorize, because you will be asked in oral pathology, in oral surgery, in oral medicine about what are the tumors of origin that will send metastasis to the jaws and to the oral soft tissues. These metastases, as we said, they can be radiolucent and they can be radio-opaque according to their if they are osteoblastic or osteolytic. Most of the jaw tumors are of osteolytic type. The bone will resorb, they will induce resorption of the bone, and they will proliferate to form a mass of a tumor that is similar to the primary tumor. But some tumors like breast and prostate, they stimulate bone deposition, but we can still identify the malignant tumor cells within the formed bone. Clinically, the metastatic tumors can be painless, incidentally identified, asymptomatic, or they can be painful, causing loosening of teeth and causing swelling and enlargement. And this is all about the disorders of bone. We finished the 4 lectures about disorders of bone. When I prepare the labs for you, I will wrap up all the information together, inshallah, and we will discuss and cover more areas, put everything together. And if you have concerns or questions, you can email me. We can arrange for a Zoom meeting, or we can arrange it later. Our next lecture will be the last lecture in the course, and it will be about TMJ, temporomandibular joint disorders. Thank you.